So today we're just going to discuss some cardiac cases to kind of work with what we've seen already and bolster our knowledge on cardiac stuff. Just disclosures. I've been involved in some courses. We have a course here at TCH. Uh, to start off, with the general paradigm for what we're going to be talking about. We here at TCH teach trying to look through everything in a protocolized manner in terms of looking at your various parameters that you're identifying within the cardiac imaging so that you kind of have a good survey of what's going on, and you hopefully catch on to things that should be a natural checkbox, and otherwise help compose like an organized way to approach the imaging that you're obtaining. So the moniker that we're dealing with right now, we're working this out, is the serial hemodynamic assessment in pediatrics, which is meant to be somewhat a little bit like APGAR, and that gives you clues as to what the components are. One would be squeeze. You're going to try to take a look at the overall dynamic movement of the heart as an indicator of how well it is getting loaded from a preload standpoint, what kind of afterload it's dealing with, or if there's an issue with myocardial function. This could be in the ventricles or the atria, and the kicker is that sometimes we don't know which one it is, and we have to put it together with the clinical context to make it make sense. We have to kind of check off the box in our head. Do we think this is hypovolemia? Do we think there's anything about the anatomy that clues us into what's going on? We can always put in the box whether or not there's something that we're worried about from a congenital standpoint, but also just like deformation that happens with various functional issues, the left going bad and dilating out, or being very small and empty, the position of the intraventricular septum. But one of the first things that is something to check out, particularly if you work in a cardiac ICU, is whether or not there's a pericardial effusion. And so going through the flow chart over here to the right, the idea is generally to, first put in your workflow. Am I going to go ahead and get cardiac imaging done while I'm trying to stabilize this patient? With a quick subcostal sweep, you can look for an effusion where you put it into the probe into the position right below the xiphoid process, and you kind of pan up and down, and you look for any kind of irregularity to the effusion, and you see if you have to work that up. And then you can qualify the squeeze on your LV and your RV. And then comes in the question as to whether or not like a hyperdynamic RV or LV might require fluid. And you can do tests for that, whether or not you want to do that with ultrasound, or you do that with the other tools that you have at your disposal in terms of looking for pulse pressure variation on your A-line or on your SAT monitor that seems pretty exaggerated, or just testing it out, whether or not you want to push on the liver, you want to raise the legs, you want to just give a small test bolus and see what happens. Hopefully, we're not just using one tool in isolation, or integrating everything that we have in front of us to try to guide the resuscitation. And if you have bad dysfunction, that might be a clue to kind of titrate what therapies that you might be given in terms of volume or afterload increasing types of things like vasopressin and norepi. With the resuscitation too, as we find that we're more fluid responsive or vasoplegic, we might be leaning towards more of a dissociative or distributive type of shock at the far end of that. We might find that we're giving fluid and we're not necessarily getting anything, and we might need to reevaluate. So with all of that, you kind of compose a montage in your head as to what's going on. You go to the end of it all, you just make sure that if there's a congenital issue, that we start thinking about, oh, hey, maybe I need to call cardiology in to help me with this, and whether or not to escalate the evaluation. Then you kind of rinse and repeat. And then also balancing that with the initial decision. Do I want to echo again? Do I want to stop what I'm doing to do this? Do I need more hands to help me manage this patient, and so on and so forth? And so things that check off the boxes going more towards the left of this flow chart, favor inotropes and afterload management. So in the case of bad LV dysfunction, whereas stuff that leans more to the right favors more of a fluid or vasopressor type of strategy. So it's just not necessarily a guideline for things, but a way that we can help at least, parse together all the data that we're going to be getting at the bedside from the imaging. Let's see. So just to review really, really quickly, what Born was talking about last week in terms of cardiac imaging, one of the images that's nice to get at the outside is just a sweep from below in the subcostal area. And the view on the left is what we would see in a traditional POCUS setup, where we put the probe at the top of the page, whereas in a traditional PEDS cardiac setup, we flip it so that it's inverted on the right, so that we have up is up and down is down. You can see that everything that lives next to the liver, which is closest to the screen, is going to be the right heart in terms of the RV and the RA. And then in addition to looking for an effusion, like we already talked about, sometimes it helps with a patient who may have congenital issues in terms of like deciding overall situs and knowing where you're going to be looking for other structures. And then it gives you kind of a good ballpark for what's going on in terms of obvious function issues. And then we can move on to our apical. I know apical tends to be something that when you're starting out is a little daunting, but the thing is, it's got the same settings usually as your subcostal. So you've got the same depth and probably, roughly the same gain and frequency adjustments. And so with your apical, you just move over to, the PMI, you point the probe right in the middle of the mediastinum, you look for relative chamber size, you can Doppler the AV valves, and then you can also drop your tail a little bit and then look up at the LVOT and the root of the aorta, and you can Doppler the aortic outflow from there too. All these things you kind of are already starting to get a sense for what's going on with the heart. You've seen all four chambers and the relative size. And then with the peristernals, I'll be fair to you, a lot of echo labs start in peristernal, but a lot also start in subcostals. The benefit of using the peristernals at the front end is just that you get a very crisp image of your valves and your chambers and stuff like that. But to get kind of that big picture, the other views sometimes are a little bit more useful, particularly for effusion. So it can be up to you. There's no rules about this specifically, but just kind of like what we recommend to folks that are training here. And so peristernal short on the left side of the screen, you put the probe just left of the patient's sternum. You angle it so that the indicator in a cardiology mode is pointing it at the patient's left shoulder. And you're able to kind of get a sense when you pan down to the LV and the RV, looking at about the level of the papillary muscles, good sense for position of the interventricular septum as well as your overall function. Then you can rotate the probe 90 degrees 90 degrees counterclockwise, align the probe with the major axis of the heart, and then fan to try to see the whole left heart in continuity from the left atrium to the mitral valve to the LV, out the aortic outflow tract and so forth, and be able to get a good sense for that. And this really gives you a good sense of structure. If you're on ECMO, it can help you with some modifications of these views, kind of figure out what if your cannulas are behaving and so on and so forth. So I just want to start with the case that we talked about in the previous talk that I did, only because it helps provide some context. And so I've trained to work at a lot of institutions, so it also gives me the benefit of calling a lot of the institutions I've worked at previously the outside hospital. So this was at an outside hospital. This is a 16-year-old female, previously COVID POI, suspected MIS-C, who's vomiting and having watery diarrhea, mild URI, and was just a little tachycardic for age, and was a little hypertensive, 70s over 30s, had already received fluid, had a right IJ in place, CVP was 5, was alert but tired appearing, capillary refill of 3 seconds. And this is just a review. We saw a patient that had a kind of mildly collapsible IVC. You can tell it doesn't take a lot of movement to be roughly about 15 to 20% collapsible, kind of low normal function, and was still kind of like borderline pressures. And so this is both on peristernal short and peristernal long. And so the answer in this case, again, from last time, was just that we had sorry, let's get this to work. Okay, we had low normal LV systolic function. We had approximately 20% IVC collapsibility index, kind of like a mixed shock picture with hypovolemia and LV systolic function issues. And so we used this as a way to know that it was safe to give more fluid. It was also not unreasonable to give some inotrope, given that we were still in shock. And it turned out that fluid ended up fixing everything. And so it's just to keep in mind the potential for multiple things to be going on at the same time. Let's see. So another outside hospital, this was another case that we have another case here with an 8-year-old who is previously well. He was in a house fire with a 45% total body surface area burn, 25% full thickness, smoke inhalation injury, was intubated, was obtended on arrival. He was put on the protocol for burn fluid resuscitation. His heart rate was 140. His blood pressures were 70s over 30s. Albumin boluses were given. It was even started an albumin infusion on top of his burn resuscitation fluids. And of course, there's concerns about fluid overload. Of course, this is the population where they're so leaky that you worry about boluses disproportionately increasing their total body water and then contributing to overall morbidity in resuscitation. And so we end up in a crossroads sometimes with these patients as to whether or not we should continue with boluses and run the risk of overload, or if we should be using more of a vasopressor inotrope type of strategy. So let's see. I want to give everyone the chance to chime in here. Don't worry, I can we can mute out your responses so that you don't have to worry about, like, this being on the YouTube and everything. But I just want to give a chance for folks to kind of look and see what they think, and I'll give you all a few seconds, and then we'll just keep going. But like, what do y'all see here in terms of these parasternal views? Parasternal short is on the left, parasternal long is on the right. Okay, so basically, we have a LV that is pretty collapsible, right? In systole, you can even see that the papillary muscles kind of come next to each other, and so sometimes we call that kissing paps, where basically the walls of the ventricle are practically coming together. You might even think, well, the wall of the LV looks a little thick, but that can also happen in an underloaded situation. So this is a patient who is just like leaking fluid, and so this would within the burn protocol, of course, if you're titrating for pressures, you would be looking at increasing your total intravascular volume. You would be also increasing your infusion rate so that you could limit the number of boluses and stuff. And so it is ultimately helpful from that standpoint and kind of helping guide that management decision. You can see that also, if you look at the IVC, it's pretty collapsed as well. And, we always have to caveat this. We'll be having this more in a volume status lecture later. This is a this is a sagittal view where we have it a little bit flipped, and I apologize for that because it's a radiology convention. We have the dot oriented to the left of the screen, the RA is over here, the IVC is over here. You can see that, we have near total collapse of the IVC with respiratory variation. We see the same thing over here, or we have that as well, with collapse of that structure. So overall, one thing that we always have to think about when we're looking at the IVC is the potential for airway pressure to cause inappropriate masking of collapsibility, but this is a patient who's intubated on a vent and is still collapsing, and so kind of goes along with the total story of a patient who's still fluid down. So hyperdynamic function underfilled, neurologic exam was not reassuring, pupils are fixed and dilated. Ultimately, this little guy unfortunately didn't survive. So this is not cardiac, of course. This is an iris. This is his corneal, this is his pupillary exam. And so you can orient a probe in plane with the iris. You kind of put it like right above the eyelid and you aim it down right across the iris. And the reason we had to do this is because he had such bad burns that his corneas were cloudy and opacified, so no one could see his pupils. And so what you can do is you can use the probe to visualize the iris, and you can still illuminate the iris with direct confrontation from the front and look for any type of reaction. Unfortunately, we didn't see that. So with the non-reassuring neurologic exam, we declared brain death, and unfortunately he passed away. Another outside hospital case. This was a 16-year-old female who had osteosarcoma in remission, was well treated from that standpoint, had a known doxorubicin exposure, and then developed chemotherapy-related cardiomyopathy, and was admitted for dyspnea and exertion and shortness of breath. Heart rate was in the 120s with blood pressures 80s over 50s. We couldn't start milrinone with the kids' pressures and start dopamine at that hospital. Did receive some fluid through the day, and then that night was acutely hypotensive. And the overall story that was being painted from another service that will remain unnamed was that, it was just, try not to escalate anything. Please try to keep this, try to see if we can, eke through with what we have, and keep her in the ICU to make sure that she doesn't need something more. And so at the time, at that hospital, we didn't have a great ultrasound. And so we grabbed the machine out of the OR, which was a anesthesia nerve block machine. And the reason I bring this up is that sometimes that's the situation you're in. You're called into the PACU for an event, and you don't have a cardiac machine around. And so on the left is an apical 4 done in the POCUS style with the apex at the top of the screen. The peristernal lung is on the right. What do y'all think? Aside from, the relative chamber size, if I couldn't see the ventricles for some reason, what else might clue me into whether or not the function is not going well or not? And you don't have to answer it, just seeing if folks might pick up on other stuff. Our valves don't have much excursion in diastole. They don't flop around too much, or atria are a little bit dilated, which goes along with difficulty in moving blood forward into the ventricles and stuff. And so function often is exactly what you mentioned. It's kind of look at the size of the LV and the RV. They don't move around that much. And the structures look blown out. But even dead heart will move because it's tethered to something else. If it's tethered to something else that is moving, so it's always. And then sometimes we foreshorten. We miss we miss the structure. And so looking at the total picture, for other clues also helps you just kind of validate that. But yeah, you're right. Most people, as soon as we plop the probe down, it's we have a functional problem here. And this was worse than a baseline echoes. And I apologize, I don't have those up. And so this was at 10 p.m. And at the hospital I was at that time, we did not have overnight echo. And so she continued to have issues. Called cardiologists to ask, can you just come in and do an echo? And the echo attending told me, look, you already got images. I believe you. She's worse. If you are talking about escalating care, just escalate care. I'm not going to be able to help you here. And this was from the echo attending. And so we put the kid on ECMO. And eventually the kid was, I think I have that in the next slides. The kiddo was converted to VAD, had a good neurologic outcome, and then was bridged to transplant from that standpoint. But at the time, it when you're in the throes of things, sometimes we can still get to the end point without necessarily having all the pieces that everyone wants there with the equipment that we have in front of us, as long as the equipment in front of us can still do the job we needed to do. So in this case, this was just an example of using, basically the curvilinear off of a OR machine to try to get a good image done. Okay, next case. This was a 6-year-old, a history of ALL in remission. This is also at an outside hospital, admitted to the PICU for respiratory insufficiency. So the kiddo recovered in the PICU, was on some nasal cannula, was transferred to the inpatient unit, and then while walking in the hallway, became unresponsive and fell to the floor pulseless. An RRT was called on arrival. The code team, the patient was already receiving CPR. And so it was never 100% clear as to what the arrest was initially instigated by. There was questions as to whether or not he also had some exposure to anthracyclines, whether or not he had some cardiomyopathy, but it never was that clear from what was going on. So this is arrest CPR, arrest POCUS, which we will talk about in another talk later on. This was kind of like at the end of a compression, when we popped down and we just like looked real quick as a compression came off the chest. You can tell it doesn't look great, but it also doesn't help you that much, because it's like someone else is squishing the heart. You don't really get a sense for what's going on. On the left here, you see some fireflies here in the RA. That's from a bolus that's being given through IV that was slapped in really quickly. And so you wonder, like, if CPR is ongoing, sometimes people talk about trying to get views, but it's a little bit tough. So unless there's like a massive pericardial effusion and you have a good window for it, it could be a little hard to see. Let up on the chest, stop like, punching the heart, and you see we have like, we have the view here. So what, again, anyone want to just jump in with like what they're seeing here? This is pretty much an arrest heart, where you have severely dilated, not really that mobile 2D image of a LV that's struggling. This is from a subcostal view. Sometimes we end up with quite a bit of dilation depending on the degree of the resuscitation. Usually it's the thinning of the LV is more associated with, like, of course, a longer term picture of cardiac insufficiency and cardiomyopathy. And so this is as arrest is progressing. You can see less and less squeeze. We can see now the spontaneous contrast of those fireflies on the left side of the heart. And the difference is, when you're seeing on the left side versus the right side, this probably isn't a bolus, right? And so this is blood that's just not moving very well. And so we can still see the heart squeezing. We see some spontaneous contrast. Remember from some of our other material that when you have an echo show up, it's not necessarily that you have something solid. You just have a difference in impedance between two different substances, meaning you've got a density difference or like a speed of sound difference in the material that you're scanning. And even though like sound travels really, really well through bone and travels really, really badly through air, both are like acoustic walls, because bone has very, very fast sound velocity and air doesn't. And so because of that difference from tissue makes both pretty much like a wall that sound bounces off of. And so you can have density differences in blood where we've got, thickening blood, but it still might not be solid yet. Or you can have a fluid flush, and that would be a density difference between water and blood that'd be marked at the time that you're flushing, just because of the composition of the saline as it squishes in. It isn't fully mixed yet, and so you get a little bit of a sonic reflection there. And then as arrest progressed, then we ended up in standstill. So this is, I apologize that the depth was not correctly set here, but this heart stopped moving basically. And so we actually ended up putting this kid on ECMO because we had already committed to it. This image of standstill was obtained while we were cannulating. And after we cannulated, this is what happened to the heart. He had recovery of function. And so in adults, it's been described as a predictor of ROSC failure. In children, it is, I would say this really needs to be reevaluated. So we initially published this series of 3 kids where we had already committed to eCPR. They manifested standstill, and we had recovery of function. So granted, the kids did awful. Codes are awful to patients, not just because of what it does to the heart, but if we're going to use it as a marker for failure to achieve ROSC, it's actually not, because you get them back on a circuit, and then you're able to recover that function. So if we're looking for tests of death, this isn't really the one to say that your heart's not coming back. And so that was the case series done with Kate Steffen down here in the Mill and Peds emergency care back in 2017. And then just last year, like looking at everything, the HA and also ILCOR have put into PALS recommendations that even though folks do use echo, even though in the PALS guidelines you can use echo to look for reversible causes, there's caution that using it for prognostication might be not well founded, only from the standpoint that we can only say so much from existing studies that said, well, I used ultrasound to test death, and then we withdrew and the patient died, and so a standstill exam is associated with death. But that only follows if you're gonna just look at the raw association. But the causation, as we know from just evidence-based medicine, is not completely proven in that circumstance. And so the kicker for me really was recently multiple stories of how there have been patients who were declared dead by standstill and woke up in the pediatric arena, who had full neurocognitive function recovery. And so that I think in this day and age, we are good with so many things in CPR. The standstill itself has not been honed well to figure that all out, and we cover that a bit in the paper published with Tom Nakagawa just earlier this year. And if I can save that for another discussion later on, but it's just something to consider, how we probably need to re-steer this thing in POCUS about standstill. It's not really a good marker for cardiac death. So another case, this is also at an outside hospital. So this is a 3-month-old female who had a TED repair, was post-op day number 3, had a conduit placement and a VSD closure, had delayed extubation, secondary to persistent moderate chest tube drainage at an institution where we sometimes had these problems. There were junctional rhythm issues, there were fluid requirements that were persistent given the losses. During care, the patient became agitated and tachycardic, hypotensive, and then became pulseless, and CPR was initiated. On the left is a paracylindral short axis view. On the right is a modified long axis view due to difficulty in getting to the chest because of dressings and stuff. So it is looking kind of like at almost as low as an apical view, but trying to get a parasternal. Exactly. And you can tell this is a complex one, right? Because you've got these septations in it. So this was a kid who was draining a lot out of the chest tubes, and the chest tubes couldn't pick it all up. And so we saw that, immediately handed the fellow a needle, and we were poking, and the attending cardiac surgeon comes in and is not happy. What are you doing sticking a needle into my fresh post-op? Literally slaps the needle out of the fellow's hand. Thankfully, no one got injured by it. And then at that point, because we had already told, the heart center knew there was a pericardial effusion and arrest in this hospital's cardiac ICU. Echo was there, and this is not the patient, but this was what they saw basically. Like, where'd that effusion go, right? So I know, quite a few of you who've known me for a while know this story, but the reason I bring it up a lot is because this was the situation where immediately, the question turned to, like, what are you doing sticking a needle into a patient who has no pericardial effusion? But the kicker was that we had those images from the prior scan. So we showed them, and it was no longer a question of what are you crazy intensivists doing with POCUS? It was like, where did that effusion go? And so it's just to say how important it is sometimes to just record your images. It usually helps you out more than it hurts you. And so what happened was that the pericardium popped, maybe with the poke that we gave or the compressions, and it became a pleural effusion. And so with that, we did a chest tube. It was bloody, just like what was coming out of the mediastinal tubes, and the kid got better. And so it's just an example of one pericardial effusion in one of the high risk populations that we worry about, and how sometimes the data that we get at the bedside helps us figure out how to connect point A to point B in our resuscitation. So next case is a 5-year-old with necrotizing MRSA pneumonia and septic shock, was cannulated onto VA ECMO through the neck. Heart rates were 120s to 140s, blood pressure 60s over 30s, had no lung recruitment. Otherwise, circuit pressures were normal, and patient's tachycardia was refractory to sedation, as well as fluid, in addition to the hypotension. So on the left, we have apical 4-chamber view. On the right, that, I apologize, is a peristernal short axis view, is just to emphasize that the imaging was a little bit tough on this one. But what do y'all think about the view on the left? And so let's just, think about for a moment. This is a kid on ECMO who is hypotensive and tachycardic, and the circuit is otherwise functioning okay. So yeah, there is a little bit of an effusion. We're able to see it better on ECMO, partly because the lungs are decompressed, and total body water is a little bit up and everything. So it is a little bit of the heart's moving around in there. So yeah, there is an effusion. You can see it on the short axis too, as well. What do y'all think about the relative movement of the left ventricle compared to the right ventricle? Left looks like it's moving a little bit more, right? This is something where I have to tell you that this is not a foreshortened view. Maybe I could have gotten the mitral valve to show up a little bit better, but like the LV was squished, relative to the right. The right, still has like good, longitudinal contraction. We can see that with how well the tricuspid moves and everything, but it really doesn't empty like the same way the left does. The right atrium like fills the right function looks overall okay there, but that's probably because the ECMO cannula is there. ECMO cannula is decompressing the right atrium. And then the left atrium is also kind of like not too impressively big or anything like that. So we have a big right, a small left on a patient via ECMO. So let me just see, move to the next clip here. It's another view, kind of like, same thing, same patient. Just trying to move around a little bit, seeing if we can get the same bigger, just a tiny LV. And so we also look at the IVC, and it's nice and big and gorged. And so this is a patient where we've got blood coming into the right. We have some level of difficulty moving the blood out of the right and into the left. And that would be, this is one of those things where we're in the PICU, we're at the extremes of physiology. And so this is a patient whose lungs were just really, really, really bad. And so we have, in a way, RV failure, but a very PICU specific RV failure, where we basically have like collapsed lungs on ECMO. And the thing is that we just were not able to move that well to blood through the heart to the left, but then it's like, well, why isn't the circuit doing more? And so it's like, well, that was the question. Then it's like, well, the circuit probably should be run a little bit faster to help decompress the right and keep blood moving over to the left side, as long as it didn't overwhelm the LV. And so what we did was we just ran the circuit a little bit faster, considered lung recruitment to try to open up the lung more to reduce PVR, considered the possibility of nitric just to see if that might help, even though the SATs were doing okay. And so some people also talk about just trying to push more fluid. The problem is that we were already getting congested on the right side. It's not the wrong answer. It's just it may not immediately have given us what we wanted because the circuit is running fine anyway. But the question here was why is it that we're acting a little bit shocky, and is it something that we can fix with our other interventions, or do we need to add something else? And then in this case, we altered our ECMO strategy a little bit, looked at what we could get with the lungs, and moved from there. Okay, Once upon a line, this is next case. This is also at Nausea Hospital. This was a 6-month-old infant who was intubated for RSV bronchiolitis. Had a history of ARDS. Oh, I'm sorry, was admitted with ARDS, had a history of prematurity at 32 weeks gestation, chronic lung disease, was on oxygen at home for a period, and then most recently didn't require it. So intubated, was normotensive, but was on 60% FiO2 for 92% saturation. At the time, we were doing subclavians in these patients, and so we decided to do one. And then the view we got was this. And so this is a normal patient, not the patient that we're the normal healthy patient. The patient that we're talking about is in the middle, and a Doppler is on the right. Just to orient, because I know this is not always a view that a lot of people see. This is a kind of a transverse cut where you put the probe sagittally oriented, kind of at the angle of the clavicle, and then you're able to look down into the chest, and you're able to see the subclavian artery a little bit more towards the head, which is to the left of the screen. And then the subclavian vein is there to the right. You can see that little flurry of a flush in there. That's when we were testing line placement to make sure that we didn't have a line in the subclavian. And then, but the patient that we have here is the one in the middle, and then with Doppler on the right. And then totally no worries here. By the way, you can see the lung here. That's just how close your subclavians live to your lungs. And so subclavian artery here, more towards the head, subclavian vein right here. You can notice that they're pulsating out of phase with each other. And of course, if we're looking at putting a line in something and you see it pulsating, you always stop to wonder about it for a moment. So then we popped it into Doppler, and then we're looking, it's like, could we have like, an obliterated subclavian for some reason? We've got branching of an artery, and we scanned the whole length of this, and both directions of flow were opposite each other, and they're out of phase. And so the thought then is like, why is the vein pulsating? And that would be because of a crazy TR jet. And so this patient, this is peristernal short on the left. This is kind of like a subcostal, almost on the way to an apical there on the right. And I apologize, I kind of gave away the answer already. But when we put color flow Doppler across the tricuspid valve here, knowing that the right-sided structures are closer to the liver, we can see the aliasing of the TR jet, and a kind of like a moderate jet going from the ventricle into the atrium. And so this was indicative of RV dysfunction. And then when we looked on short axis view, of course, we have flattening of the septum here in the view on the top with the short axis view. The reason that we have bulging of the septum into the LV in diastole as the chambers are supposed to fill is that you regurgitate that blood back up into the RA, and then it comes right back down at you. And so in diastole, you get like an excess fluid rush back into the RV, and so pressure overload would be constant afterload issue that keeps the septum deviated. But when the septum becomes more deviated in diastole, it's more of a volume problem. So usually think of a tricuspid regurgitation, or if you have a shunt of some sort. So the patient was started on nitric, and clinical status overall improved, and we was weaned off in 3 days. This was a case we actually wrote up for the ASC's case report journal. It's called Case, and you can find it here. It's in open access journal. And then the other clues that you can sometimes see if in a pulmonary hypertension kid is that you can be looking at the IVC view, looking at here the IVC coming up into the RA. You can also Doppler the hepatic vein. In normal condition, all the blood is going blue away, right? Blue is traveling away from the probe, going towards the RA here. So both your IVC and if your IVC is kind of tilted on this angle and your hepatic vein are oriented this way, you can see the blood flowing that way. But in this orientation, so this is actually the hepatic vein on this patient. The IVC goes this way. It's a little bit harder to see, but we can see the TR jet regurgitate all the way up the IVC, up the hepatic vein. And you can see the Doppler coding for the flow shift back and forth in systole to turn red in systole if it's if you've got significant RV dysfunction. And this gets into Vexus imaging, which we will probably be covering it at a later talk. So take homes are practice. Everything gets easier with just getting more and more familiar with what you're looking at, what you're doing. Make using the machine easiest for you. So take care of it. Make sure that it. There are things like we clean it. We make sure that the cables are in a reasonable configuration, as you can see on the image on the right. You make sure that we're not like stressing the battery so much, like running it unplugged and then leaving it unplugged all the time, and the battery dies, and then whenever you disconnect it from the wall, the whole machine dies and stuff. And then this whole talk would not have been possible without recording images. And so again, it's just better for everybody. It's better for you. Decisions that you make are well substantiated. Nobody has a full echo done every morning at 7 a.m. And so when we're rounding with the surgeons, we had that available. And then it's better for the patient, of course, in terms of just having a good record for what's going on. And I just always have to say, sometimes you're wrong, but the thing is, like, when it's hard to make wrong right if you don't have something to work from. And so having those images over time will help you just become better and better at what you do, and have the record of proving to yourself and to other people that you can do it. And that's it.